Oh, hey, Chris.
Hey Chuck, how are you?
I'm great. How are you? We're recording this on Memorial Day weekend. We got a couple days to chill. Neither of us are on call.
Yeah, I was not gonna reveal when we were recording it, but now that the cat's out of the bag, I mean, kind of can talk about what we're doing this weekend. But yes, it's nice. We are in town and just relaxing and having people over at various times. But it'll be a good weekend for me, full of culinary adventure. Yeah, always looking forward for opportunities to stretch my comfort zone with what I'm cooking.
Well, how adventurous culinarily, if that's a word, can you be if you happen to be hosting a birthday party for one of your children?
Well, so tomorrow is going to be like my daughter recently turned 8 and she's having some friends over for a sleepover tonight. So we're going to make her favorite dish of the moment, which is, you're going to laugh, a copycat version of Olive Garden's fettuccine Alfredo. She loves.
I
And
get that.
I mean, what's not to love about that? But
Yeah.
with some grilled chicken and some broccoli and whatnot, so it won't be completely it'll be somewhat healthy. But so doing that, so that's not an adventurous thing. I think I'm gonna smoke some meats overnight on Sunday in the smoker and kind of try some new things. Haven't worked myself up to a brisket yet, but we'll do some pork belly burnt ends. And we'll do some. There's this really great maple bourbon glazed pork butt that turns into a lovely pulled pork, and probably do a smoked chuck roast. Just a couple things
Big
cooking. Well,
plans. Big plans.
big plans.
Um,
So that's
yes,
what's
I
exciting me
love
right
it.
now. That is what's keeping me going at this point.
Yeah, I we're going out to a nice dinner, a new place which is getting rave reviews, and just having a chill weekend. It's interesting. My son, the fourth year medical student, leaves and will be gone for large part of 4 months. He's doing three away rotations, and so it's be interesting. It's gonna be exciting for him to see different programs, and I'm living a little. I don't say living. I'm learning vicariously about the state of medical school and application for residencies and the like.
It's crazy. Like every time that I do the interview process, especially when I did residency interviews, I thought about how now I'm that jerk on the other side of the table potentially. Whereas like, my child may be in that position applying for something, in 10, 15, 20 years. And I'm like, oh man, who's going to be across the table from him or her?
That's colored me of that same experience. Well, the listeners who know me could possibly disagree, but I don't think I'm a jerky interviewer. You interviewed with me. I just try to talk to people and get a sense of them, and maybe that makes me a little less effective in understanding people. But I think I learn about people and hopefully don't come across as a total jerk.
No, I think it's not so much the jerk during the interview, but it's the spicy comments that follow as soon as the door closes when they leave.
Yeah, well,
But
that's
anyway,
fair.
we've got some fun things to talk about today. We're gonna go through kind of a potpourri of topics, ranging from like when patients travel to see you, one bone forearm, and then some pearls about cubital tunnel, and maybe a recent distal radius case. Before we jump in, we should thank our friends at Practice Link.
Absolutely. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join Practice Link for free today at www.practicelink.com/the upper hand.
So it is interesting for the young physician starting out, it is highly flattering when people travel to receive their medical care, receive their surgery largely. And I used to be, I don't want to say competitive, but there's a certain group of people, especially with congenital hand surgeries, a certain group of patients that will doctor shop. And I don't know if they're looking for the answer they want or just want to meet a bunch of people. But there's a circuit, and St. Louis is on it. And then there's other people who just read what you've written and really start to understand and connect with you online, and they travel. I used to be very competitive, and especially for the folks on the circuit, and really wanted to win and have all those patients come to St. Louis. I don't feel that way anymore for a lot of reasons, but I'm curious. You certainly have people travel to see. I'm curious as to your perspective.
I think that it is very flattering as a younger person earlier in career to have somebody want to travel. It does feel like it's quite a bit of pressure. I've had a couple of people that have made the circuit for nerve and for plexus. Most recently, somebody from New York City who has a very bad injury, who has seen the kind of standard players, HSS, Mayo, us, two people at our institution, and also Ortho Carolina. And, three of those places are actually in our multi-center study group. So I'd see all these like screening logs come up, and then it's like, who's going to do the surgery? And for many reasons for this particular case, I'm not bummed. They picked a great team, and because it's just a really tough case with an uncertain outcome, regardless who does the case. But yeah, no, it's one of those things where I don't know if I ever feel competitive. I'm not, I think, at that stage in my career where I can, fully go toe to toe with some of these giants. But I'm pretty confident in what our team does and the work we can provide and the research we've done to support it. I think it's always hard to figure out like when somebody does commit to having a surgery with you from out of town, how you handle that, like how much of a relationship you try to establish. I don't know if you ever feel like you have to like make it worth their while to come see you, aside from the surgery part of it.
Yeah, I guess there's different ways to think about it. Um, and I've done it both ways, where it's very in the office. I give everyone my cell, or almost everyone my cell, as you know. So they have that. I can text, just the kind of how you doing text. When people travel a long way, it does feel like, and a lot of people are going to disagree with me, but it feels like I owe them something. And that's a weird thing to say. I may not be saying exactly correctly, but for example, right now, there are two families in St. Louis who are from outside the United States who have rare congenital conditions. And I'll leave it at that. And delightful people. One of them staying about 3 months, the other is probably staying about 6 weeks, and I check in with them a couple times a week at least while they do their therapy. And I see them outside the hospital. And like tomorrow morning, I'm going to bring the two families together, actually, go to Hello Juice. Yeah, just kind of, buy them some breakfast, talk with them. And clearly not something I have to do. But I've gotten to know them and the kids, and I think I'll be connected for a long time with these families.
That's really impressive. I mean, I think that at this point in my life, am, I won't say struggling, but trying to appropriately allocate my emotional energy in a lot of different things. And a lot of that is making sure I have enough energy to show up at home and enjoy this time in my kids' lives and the time I have with my wife. And I don't think I have that. Like right now, I just couldn't do that. Like what you just described, which is amazing. And I'm impressed that you have that energy and interest to do it. I just don't have that right now.
I think that's right. I'm not sure I would have either. I mean, right now I'm in a very different life stage, and I'm fortunate to have two of my three kids in town. But they got a lot going on, and if I disappear for an hour, I'll probably bring my wife because she's wants to entertain and get to know these people. And yeah, it's interesting. It's a self-imposed burden, but one that I find rewarding. The relationships are rewarding. I think you would obviously agree with that in general. For most of our patients, the carpal tunnel releases, the simple stuff, there is no real relationship. They probably forget our name in 2 years or sooner. Bigger surgeries and bigger problems, I think there's more of a bond.
Yeah, it's interesting. Couple of follow up points. I was at Costco today and I was doing something, shopping for bread. I was in the bread aisle and I was talking to my son, and then a woman stopped and she said, "Hey, you did my hand surgery." And I just had this blank look on my face, and she just shows me her incision, and she's like, "It looks great. I'm doing really well." I was like, "Thank God." And then
Yes.
I guess the only other thing I offer to patients coming in from out of town is I make sure to offer excellent hotel and restaurant recommendations. It's the best I can do. I've had this string of patients coming up from Birmingham, your neck of the woods, to come see me, and I've tried to deliver on appropriate culinary recommendations. And then I remember there's one time where I was invited to speak at the hand therapy meeting, which was in St. Louis, and we had a really cool panel that involved talking about kind of multidisciplinary brachial plexus care, which involved one of the hand therapists I work with very closely, Jamie Findice, as well as a pain management physician, a United Brachial Plexus Network advocate, and one of my own patients. And when he gave his, story of what he went through, I mean, there was not a dry eye in the audience. And he got a standing ovation. And then, like we got dinner afterwards as a group, and it was really, really nice to have that opportunity to kind of get outside of our doctor-patient relationship and just, enjoy a company together, which I have not done very often with patients. So that was a really, really cool moment.
Yeah, I think some listeners will feel that we are maybe crossing a line. I definitely don't feel like we're crossing a line, but it's certainly as you know, and maybe people have discerned, in clinic, I'm pretty businesslike. How I engage and kind of what I do, and it's not extraordinarily personal, especially with the busy clinics. And some of our partners get more personal. Not my style, but in some of these relationships, sometimes there's a relationship, and maybe that makes the kind of balance out. I don't know.
Yeah, as I've learned from the fellows, and I've realized myself, I'm much more Goldfarbian in clinic than some of our other partners in terms of I conduct myself, I think, pretty similarly to how you do. I will have one question. I think a lot of people are wondering. You mentioned that you give your cell phone out a lot. How often have you been burned by that?
Almost never. Like it's incredible. Um, People do not take advantage of it, and occasionally people will call and they'll be like, "Oh, I thought I was getting the scheduling line or something," and occasionally people will text and ask about something, but it's rare. And honestly, in those situations, I usually pass it on to my nurse Nermina, who's amazing. Occasionally, I'll just call them back and deal with it, but yeah, almost never.
That's really impressive.
Yeah, maybe I'll get burned. I don't know. I haven't. It's been a long time. The other thing I'll say is and it's interesting. I learned something yesterday. I had a clinic yesterday on a Friday afternoon, which I haven't done in a long time. But when I call patients after surgery, if they have this new thing where you have to announce yourself and they say, like, please say who you are and why you're
Yep.
calling, I hang up immediately. It just drives me bonkers. So
hmm
the therapy line was down yesterday over at Millikan Hand Therapy. So I was in clinic. I needed them. So they had someone had given me their cell. And I called and I said, this is Charles Goldfarb and I'm calling from over in clinic. And they answered, it's pretty quick. They answered quickly. And I said, I just have to ask, did you know your cell phone has this thing? They had no
hmm
idea. They had no idea.
Really? Huh.
No idea.
Huh. Huh.
Anyways, interesting.
Yeah, that thing drives me bonkers when I'm calling families after surgery. I've not gotten myself to the point where I'm calling patients the day, after they've left the surgery center like you do. But yeah, that does drive me bonkers. So we're going to jump into a topic that you wanted to talk about, a one bone forearm. But before we do, I wanted to mention that Checkpoint's newest biomaterial product, ACM Shield, is quickly becoming a valuable solution when nerve protection matters most. A newly published animal study conducted in collaboration with the Mount Sinai Upper Extremity and Nerve Lab highlights the clinical value of ACM Shield, and a five-patient case series demonstrating its use in revision compressive neuropathies is now available.
With more than 800 units distributed since launch, ACM Shield continues to gain traction as an effective option for nerve protection. To learn more, visit checkpointsurgical.com. Before we jump into one more form, can we talk about um, a picture I sent you from the OR this week?
Ah, yes, yes, yes. Let me pull up the picture, but you very rarely send me pictures, and especially of a nerve thing. But you were very excited about this. Do you want to tell us a little bit about the context of the case and why you felt so compelled to take this picture?
Yeah, and I try to take pictures because we do a great indications conference, and the kind of the clinical pictures make it special. So this was I think a 17-year-old pitcher who had classic cubital tunnel, but before surgery, he pointed to the mid-arm level and said that his nerve seems irritated there as well. And sure enough, he had a marked Tenell's at the cubital tunnel, but he had irritation much more proximally and honestly higher than I usually proceed with my ulnar nerve treatment. And so, I don't make a small incision for ulnar nerve transpositions, but I also want a respectably small incision. I don't want a massive incision. So in this case, I went more proximally than I usually do. And it was just a really, I thought, impressive example of the triceps clearly compressing the ulnar nerve.
Yeah, I think that's one of the reasons, so the historically, the Arcade of Struthers has been described to be about 8 centimeters proximal to the medial epicondyle. But I think, I guess the story that Dr. McKinnon says is that for a while she, would say that that's not true. Arcade of Struthers, isn't there. Uh, but then she said that now she goes more proximal and sees it much more proximal. So I think that's probably kind of what you're running into. And the reason, and she taught me that, and that's the reason why I use a sterile tourniquet, is I don't ever want to get boxed out. Because some people have, varying lengths of their brachium. And I think that that sterile tourniquet gives me the opportunity. I think if you look hard enough, you will find something. I think your picture's pretty dramatic because not only do you have that kind of transverse band of tissue that goes between the medial and osteoseptum and the triceps fascia, but it actually is a large triceps that is running over the ulnar nerve more proximally. So that is more of an additional compressive point, and then you can also see how that could be dynamically irritable to the nerve with repetitive elbow extension and firing of that medial head of the triceps.
Yeah, and I guess the question is, usually what I do is I go, what I think is a reasonable length proximally. I use a Army Navy to lift up the proximal aspect of the incision, or two Army Navies, and I just make sure that I don't feel like the nerve is compressed. Um, how do you know when you're far enough?
I don't think you ever truly know, but it's diminished. I do think it's diminishing returns unless you have some reason to believe that there's something proximally compressive, like the clinical examination that you mentioned, because you can continue chasing that and you'll never find it. Because there are a lot of patients who don't have that robust kind of transverse arcade. Most people, I would say, don't have that. But I think the things, aside from your clinical exam, the things that make me concerned are, if you have somebody in a revision setting, that's obviously one where I'm going to make a bigger incision anyway, and I'm going to have kind of uh, a high suspicion for some other weird anatomic abnormality or tight structure in addition to what's typically found, which is either it's getting pinched by the septum or it's getting kinked with a Z deformity down where it makes its downslope after you've transposed it.
Yeah, a little bonus for those of you on YouTube. So you want to tell, well, I'll tell you what I see. So you can see obviously the cubital tunnel, which is a little bit hidden by skin. You can see the nerve coming proximally. You can see the robust triceps and really covering the nerve. You can see the medial intermuscular septum heading proximally. And I just did more, I released that fascia over the top and just went way up close to the axilla because at this
Hmm.
point I could get subcutaneous. So I just thought it was interesting, and we don't talk about how proximal is proximal enough.
How do you handle, and this is a little bit different. Was there any role for recessing or excising some of that muscle that was overlying the nerve after you was it still overlying the nerve after you transposed it? And is there a role for resecting any of that muscle?
Yeah, I think there can, obviously, the snapping triceps is the most classic example of
Hmm.
when you need to consider the muscle, maybe adjust its insertion. In this case, once I'd released the fascia, once I'd excised the medial intermuscular septum and worked a bit more proximally, the nerve, once transposed, was not compressed, so I did not have to take out any muscle.
How often do you see a symptomatic snapping triceps?
I would estimate it is 1 out of 20 times I do a cubital tunnel. Um, and that is so weird. Oh, you were gone for a second. I would guess 1 out of 20 times I perform a cubital tunnel. Now, my population is not yours, but it's not uncommon. What about you?
Um, I don't see it that often. I think it's because we have different populations. I've had to do a couple of kind of resections of triceps, a little closer to the olecranon and medial epicondyle, just because it is symptomatic. And I was like, well, I'm there. I'm happy to do that for you. But again, it doesn't happen that often. I was giving a presentation recently at a sports medicine CME conference, and whenever I give a presentation about nerve issues in athletes, the talk always includes something about ulnar neuritis and ulnar nerve instability, and particularly in throwers. I often quote your article that you wrote with my co-fellow Kurt Henn about outcomes after either decompression or transposition in that kind of younger athlete population. What's your current thinking? Has anything changed since you guys published that article about when you decompress alone versus when you transpose in that kind of younger athlete thrower population?
Yeah, short answer is I don't decompress in the adolescent and in the thrower. I just think it doesn't address the primary issue with his, which is traction and torque on the nerve. And transposition is really the only thing that works. And again, I hope listeners might share differing opinions, but I feel pretty strongly about that. I think to me, at least the way my brain works, there are two things that are somewhat unique about the adolescent. One is that it's always a transposition. And I would say almost always a subcutaneous because I don't want to mess with their muscle, especially in a thrower. And then if you flip things around and go to the wrist, when I think about a TFCC injury, if the ulna is neutral or certainly if it's long, I always shorten the ulna in the adolescent. And I think there's literature supporting both of those, but those are the two things that immediately come to mind on how I treat an adolescent different than I may treat a young adult.
Right, right. And I think that the important point about not messing up, not wanting to bugger their flexor pronator mass, I think does matter probably more in that thrower, more so than people who are no longer in that stage of their life.
Yeah. So, when I travel, and you and I have talked about this, we feel fortunate that people come up to us and they talk to us about the pod. We don't give the people what they want, at least the people that talk to me, they want congenital. So I think we have a congenital-ish topic that can be extrapolated to patients of any age, and it's not a common issue, but you mentioned it. What is a one bone form and when is it appropriate?
Yeah, I have very little experience with this, so I'm looking forward to you just teaching all of us about the one bone forearm.
Well, I don't want to give a diatribe, so as usual, interrupt me, but I'll start it this way and say usually this begins with some type of injury at the radiocapitellar joint. And fundamentally, most commonly, it's a congenital anomaly. It may be a congenital dislocation of the radial head. It may be an ulnar deficiency where the radiocapitellar joint is not normal. But it can also be after a radial head excision where you don't have longitudinal stability. So again, in my population, and we looked up, well, let me back up. So when one considers a radial head excision, I always discuss with patients the risk that without that radial head, the radius can migrate proximally. And if the radius migrates proximally, even if it's only a couple of millimeters, and then presumably the interossseous membrane tightens, then you have a prominent ulna distally with the risk of impaction. Am I making some sense?
Yeah, absolutely. I mean, the forearm is such a complex joint in and of itself, and obviously there are considerations, for the elbow and for the wrist. But that longitudinal stability of the forearm is something that has been vexing orthopedic and hand surgeons for centuries.
Yes, I actually had the pleasure of reviewing some boards cases with one of our previous fellows this morning, and they showed me a case where they were considering an S6 Lopresti injury. They fixed the radial head, and we ended up talking about how to, bring that up in boards because, anytime you fix radial head, you have to think about that.
Hmm.
So in the congenital population, I really worry. And a long time ago, we wrote a paper about what is the risk of needing to shorten the ulna, and it's certainly higher with a congenital anomaly. The case I have this coming week is of a patient who had a radial head excision, and the radius just kept migrating proximally. And this was
Hmm.
discussed preoperatively as a risk, and ultimately, there's just too much longitudinal instability. And so we are going to address it. And in long conversations with the family, I think they're happy with the approach and it's going to work out really well. It's a hard decision to make for families because they recognize that if we do some type of radial ulnar fusion or one bone forearm, we can talk about the difference. You'll lose forearm rotation. And while I don't think that's a big deal, it's a really hard decision to make for families.
What's the clinical situation now? Is it a lot of pain at the wrist, the ulnar side of the wrist, or is it more of a limited forearm rotation or pain with forearm rotation?
Yeah, it's a
All the
little bit.
above.
Yeah, well, it's actually interestingly, she's probably 5 millimeters positive at the wrist, but not painful. She has a little bit of limited rotation, but the main issue is impingement between the proximal radius at the site of the radial head excision and the distal humerus. So it's
Hmm.
that with limited elbow flexion. So
Okay, so you mentioned two different options. So, you mentioned a one bone forearm or a radial ulnar fusion. Can you break those options down for us?
yes, I'm a believer that the radial ulnar fusion is a very reasonable approach. It essentially you decorticate between the bones. You can use and you have to end up excising the proximal radius, and you can excise the distal ulna. You can put one or both bones between the radius and the ulna, and then you put either a plate and a few screws or just a few screws from the ulna to the radius with or without something in between. But you have to decorticate a lot. And for me, it's always trickier getting the rotation where you want it. And so I favor creating a one bone forearm. So that means you have the proximal ulna and the distal radius, and you excise the proximal radius and the distal ulna. And you essentially then just fix it. I end up using typically a small frag 6 hole plate. You can get compression. It's not quite as simplistic as it may sound, but it's easier for me to dial in rotation. And we dial it in as from either neutral to slightly pronated. And it's a very, very reliable procedure. And this, the negative, of course, is loss of forearm rotation, but the positives are really notable for families. So I really like doing it.
I think for the last couple of decades, we've said, we live in a pronation world with keyboards, but I guess now with smartphones, do we live in a neutral forearm rotation world?
Well, I do think smartphones are more neutral, but perhaps slightly pronated, as mentioned. And the beautiful thing about neutral to slight pronation is you lift your shoulder and you're pronated. It's really hard to recreate supination, but thankfully, you don't need it very often.
Yeah. Yeah. Hopefully they're not begging on the streets because then.
Hopefully not, or holding their, culturally though, I do think
Mhm.
there's some significance with how we eat and,
Hmm.
which hand it might be and all those kind of things for Eastern cultures, especially.
Yeah, got to hold that bowl of rice, man.
Absolutely. So, anyways, thanks for humoring me and letting me talk about one of my passions. We can do it
How
again
many how
sometime.
many one bone forearms do you think you've created in your many decades in practice? In your
um,
quarter century in practice, if not
well, you want
more.
to know a cool fact, which I had to count up because there's just some stuff being written. I've treated 10 children with mirror hand, which to me strikes me as a very large number. It certainly doesn't give me all the answers or make the results perfect, but that's been fun. I would guess a similar number of one bone forearms. I'm trying not to be the surgeon who doubles what they've actually done, and therefore you have to divide it by two. But yeah, I
No
think
surgeon
probably.
ever, no surgeon ever does that. What are you talking about?
Of course
It's
not.
funny
Of
when
course
you
not.
when you when you have the receipts on people because you have it with Could and we have it with Planet in terms of like you kind of know what people actually do volume wise,
Yeah,
or it's just they're not enrolling people in your study, which is also kind of sad too.
kind of frustrating. Yeah, yeah. Awesome. Well, this was fun.
This was fun. I think we should in the coming episode, we'll probably end up going through the what's new in hand surgery that was released in JBJS recently. Yeah, that'll be a fun one. And if anybody has any ideas for topics, suggestions, please feel free to email us handpodcast@gmail.com.
Absolutely. Have a good time this weekend. Cook up some delightful food, and I look forward to hearing about it.
Yeah, enjoy yourself as well.
Thank you.